Good evening. We're going to talk about the topical subject of pandemics in the past and now, with emphasis on institutional responses in the past in workhouses, prisons and hospitals, and now in nursing homes, direct provision centres and hospitals. We've got a terrific panel to discuss these issues and the broader history of pandemics and virology, with particular focus on the so-called Spanish flu of 100 years ago, the last global pandemic with considerable effects on society. Our panelists are Luke O'Neill, Professor of Biochemistry at Trinity College Dublin, Dr. Ida Milne, whose book Stacking the Coffins is the definitive account of the Spanish flu in Ireland, Dr. Cillian de Gascoigne, Director of the National Virus Reference Laboratory and Chair of the Expert Advisory Group to the National Public Health Emergency Team, and Fintan O'Toole, Ireland's best-known journalist, columnist in the Irish Times, author of many books, and commentator on the current handling of the COVID-19 pandemic. I want to say a few words about the Grangegorman Histories Project. In the past 250 years, Grangegorman on the north side of Dublin has been the site of a prison, a workhouse, and a very well-known mental hospital. Thousands of Dubliners and others pass through these institutions, very unwillingly, usually. Now it is being fully integrated into the city as a health and education campus. Grangegorman Histories is a public history project of Dublin City Council, the Grangegorman Development Agency, the HSE, local communities, the National Archives, the Royal Irish Academy, and the new Technological University of Dublin, which has taken over that site to very interesting and transformative effect. The Grangegorman Development Agency and the Royal Irish Academy will lead a programme of research and shared discovery into the social history of imprisonment, transportation, early public welfare, and the treatment of mental illness since the mid-19th century. The planned programme of events, exhibitions, publications, and learning opportunities will help to uncover the history of the site and its surrounding communities. There will be a professionally structured oral history project to capture the memories of local residents, many of whom worked in the mental hospital. The Grangegorman Histories Expert Working Group, chaired by Dr. Philip Cohen, has been appointed to realise this programme. All of the information relating to the project is detailed in our foundation document, which you can download from the website at www.grangegormanhistories.ie. We already know that Grangegorman had direct experience of a series of epidemics since the 1800s. The Richmond Penitentiary site was considered instrumental in the containment of some of the infections that blighted the 19th century, particularly the cholera epidemic that swept across Europe in the 1830s. Even before the penitentiary accepted its first prisoners, it was employed as a fever hospital during a typhus fever outbreak in 1818. In 1832, the big year of the cholera epidemic, the Richmond Penitentiary served as a temporary cholera hospital when this epidemic claimed the lives of 4,478 Dubliners alone between March and December of that year. The disease was highly contagious and deadly, killing victims within 12 hours of infection. In 1832, the Cholera Board published a proclamation appealing to people to remove the sick to hospital, to ventilate rooms, to scrape floors, and to wash and disinfect surfaces with lime while burning and replacing straw bedding. Only recovered patients were to self-isolate, quote, not to visit in a family or go to a place of worship or to any crowded assembly, end quote. Now that sounds very, very familiar to us today, and that was 1832. This treatable disease struck most devastatingly in poor, overcrowded housing without a clean water supply. We know that the garden of the penitentiary became a cholera cemetery. In 2015, trenches were unearthed by construction workers near the Broadstone Lewis, and remains of thousands of individuals were excavated from charnel pits. A single headstone was found on the plot, that of Anthony Dunleavy, who died on the 28th of July, 1832, during the peak of the epidemic. Further outbreaks of typhoid, cholera, and beriberi spread in the institution, and in 1897, the penitentiary was again taken over as an isolation hospital to contain the outbreak. So there are multiple histories to be explored in this significant area of northwest Dublin City, now with the capacity to focus on the individuals who were incarcerated and treated there, and those who worked in the various institutions which provided employment to generations of people who lived in the surrounding areas. Another important aspect of the project is a partnership with the HSE to properly open up historical mental records for research by scholars and for family history. We're hoping that protocols can be created to release records not just from Grangegorman, but all other surviving archives of mental health institutions in this country. This will greatly enhance our knowledge of medical and psychiatric treatment, social history, and the pivotal place of these huge institutions in their catchment areas. We're very hopeful that this can happen before too long, and I can tell you that there is a huge treasure trove of records relating to mental hospitals all over the country, some at the moment in quite severe danger that need to be rescued from the hospitals where they still are, some in better conditions, but between them all, they comprise, in a sort of a way, a shadow social history of 19th and 20th century Ireland, and we're very excited about finally being able to open these up for research. So now to our patient and wonderful panel. I'd like each of you to give us 5 minutes or so on particular aspects of past and present pandemics. So, Luke, I'm going to start with you. And if you remember, over a socially distanced drink in Galway not too long ago, you revealed to me that you had a lot of information about pandemics and present pandemics in the past and the one that we're having now. So I would like you to see if you can take us, as you did me that night in the Radisson Hotel, through them. And if you want to congregate on the effect they might have had on congregated settings, please do so. Luke.
Yeah, Katrina, but it's very interesting you mentioned cholera there, remember. I mean, as we all know, there were lots of pandemics all through human history. As soon as humans evolved almost, we begin to see infections begin to spread. And the main reason is we begin to gather in crowds in accommodation. Agriculture was a big factor here, for instance. We pick up infections off animals. They give us infections and vice versa. TB is a great example. We probably infected animals with that instead of them infecting us, for instance, you know. So there's a long history of infectious diseases afflicting humanity. And the history of humanity really is about the immune system, because the immune system had to deal with these infectious agents. And it was very often an arms race then, because a pathogen would evolve a weapon to beat the host to survive, and the host then would make a new weapon to counter the pathogen. And much of what we do actually is called host-pathogen interactions. So it's a fascination to think that humans get afflicted with these pathogens over the millennia. And again, the reason does seem to be things like overcrowding, domestication of animals are the two big factors, we think. In other words, if we look at humans as noble savages, shall we use that term, nomadic, sparse populations, there wasn't much infection in those times. So in many ways, it's almost as if the invention of things like agriculture and cities and towns propagates pandemics through history. And then if we look at the human body now, we are sculpted from that battle. And let me give you one quick example, HIV. So HIV/AIDS, as we all know, devastating in the 80s. We all remember, those of us who are old enough, the devastating ads of headstones collapsing and so on. Science delivers on that one. We don't develop a vaccine, of course. It's very difficult to get a vaccine for HIV for various reasons. But we make antivirals that kill the virus. And they're successful. I mean, HIV is now no longer a life-threatening disease. I think last year they showed if you had HIV, you would expect to live as long a life as if you hadn't. But remember, a fraction of the population are naturally resistant to that virus. There's a thing called CCR5. There's a variant in that in your immune system. If you have that variant, you never get HIV. Now, if there'd been no treatment for HIV, and if that virus had let run loose through the Earth's population, a lot of the Earth would have become, would have died out. The ones who survive happen to have, through dumb luck, by the way, the right variants in the immune genes to defend them. And that's the case for all infectious diseases. Our bodies are descended from people who naturally resisted infection. So it's a fascinating business, this idea of built-in resistance and how we resist infection. The last thing I would say is, Katrina, your cholera story is very interesting. I mean, cholera was a devastating disease. It came and went. Herd immunity was never achieved with cholera naturally. Remember, that's a very important point. We keep banging on about herd immunity. That never happened for any natural infection. You would see immunity build up in the population, of course, and the virus would go away for a while, but it would always reinfect. It would come from somewhere else. A different tribe would have it, say. Or babies are born with naive immune systems, and they would pick up the virus, and now it propagates. How do we beat cholera? Antibiotics, first and foremost. Alexander Fleming begins with him, and he discovers penicillin. And then the vaccine is discovered for cholera as well. Now, we still see cholera, of course, in certain parts of the world. It's still a dangerous disease. In the developing world, it's eliminated from rich countries because we have vaccines and antibiotics to treat it. But there's an example. We'll never see cholera in Dublin again unlike back in those days that you just spoke of in Grangegorman. That won't happen again because science came along to beat it. And of course, to finish, our hope is with COVID, we will see a vaccine or an antiviral, you never know, will come along to beat this particular virus. So there's a few opening thoughts for you.
Thank you so much, Luke. That was a wonderful trip through the battleground of infection and what it does to us and how we're sometimes able to resist it, but how we have to rely in the end on science to save us from the overwhelming effects of these things. Ida, I'm going to move to you next. Your book, Stacking the Coffin, says it all in the title in many ways, that it was impossible for the authorities to keep up with the speed of death in Dublin at the time when that happened 100 years ago. It's a really vivid account of what happened during the Spanish flu. And you've unearthed all the relevant statistics and numbers. So you're going to talk to us today, and thank you for this, about a few of the institutions that were about at the time and how they dealt with the Spanish flu. Ida.
Yes, as you've pointed out, institutional records can be really revelatory about what happens during epidemics and pandemics. And in one way, they can show the extent of the crisis because they can be completely silent on it, because people just didn't have time to keep the records. And then other institutions can really show a great deal, as you say, mirroring the rest of society on it. One group of records, which I found absolutely fabulous for studying the 1918 flu, was the General Prison Board's records, which have a voluminous correspondence about it. And they showed the parallel tensions between the pandemic and the political situation, which again is heightened by the fact that so many of the nationalists are in prison, whether through the Defence of the Realm Act prisoners in Ireland, say for example in Crumlin Road Jail. They create a lot of tension through the newspapers to try and get better care for those members who were sick with the flu. And then again, because of the German plot, because several of the nationalist and anti-conscription campaigners are interned in the UK at the time. So a lot of this tension feeds back into the domestic prisons as well. When two members of the German plot group, Pierce McCann and Richard Coleman, die in English jails. The Irish prisons become very sensitive to the idea that political prisoners could die in Ireland. So they're constantly talking about, the need to keep a calm in the jails. But indeed, only one prisoner dies in an Irish jail from influenza during the period, and that's a female prisoner in Derry at the time. In terms of the mental institutions, there is asylums for the insane, as they were called at the time. They see about 400 extra deaths in 1918 and about 200 extra deaths in 1919. They have a massive issue when the staffs keep going sick. For example, in Sligo Leitrim, in August 1918, the maintenance staff have to come in nurse because so many of the regular psychiatric staff are ill, that the maintenance staff are called in to take over from them. And in one of the asylums, there was a breakout. The other area I think is absolutely fascinating is the workhouses. There are 3,329 extra deaths in the workhouses right throughout the country in 1918. And 2,500 of those are certified to influenza and pneumonia. About 500 others are certified to heart disease. So it shows again how it's not just about deaths directly from the disease that's causing the pandemic, but associated deaths, that can exacerbate other illnesses as well. The workhouses, infirmaries very quickly become overrun during the pandemic, and they would would often have to take over rooms in other parts of the workhouse, as well as in infirmaries themselves. The deaths dropped back quite swiftly by about 3,000 the next year, so it wasn't as much a problem at all from April 1919 as it was in the year to April 1919, which was the main year of the pandemic.
Okay, thanks, Ida. I think the Spanish flu killed about 21,000 people in Ireland in those years. You can correct me if I'm wrong about that. But it gives us an idea. A lot of what we heard there, particularly about the mental hospitals, strikes a familiar note in terms of what happened here in nursing homes, and luckily not in direct provision centres. But it is something to bear in mind when we look at the whole business of institutional care. Cillian, you next. The history of virology is a story of fascinating discoveries, many of which led to life-saving treatments and vaccines. Will you tell us a little about the history of virology and some of these discoveries?
Yes, thanks, Christina. I suppose we're talking about Spanish influenza, and I think that's really defined probably the last century of virology in many respects, purely because it was the pandemic in 1918 that led to a significant amount of interest and in trying to ascertain the cause of the illness, because prior to that outbreak, people in infection at least will be familiar with Haemophilus influenza, which is a bacterium that was discovered by Pfeiffer, and he believed the reason he called it Haemophilus influenza was because he believed it was the actual cause of influenza itself, which of course it wasn't. The name influenza, I suppose, predates what we now call the virus. And Spanish flu, I suppose, was so important over the last centuries because it, after the initial massive impact it had on society globally and on the population, it became our seasonal influenza and really stayed with us for the last 100 years. Again, people of a certain age will remember the 1957 Asian flu and the 1968 Hong Kong flu. And even though at the time, from a virology perspective, we were looking at antibodies to characterize those viruses, and we knew that they were different from the H1N1 in 1918, we know now from molecular work that has been done in the last 20 years that in actual fact, that 1918 virus provided the backbone to the 1957 influenza virus, which was labeled H2N2 at the time, and then the 1968 virus, H3N2. So from an antibody or serology perspective, we thought they were different viruses, but we know now that Spanish flu is actually providing the backbone to all of those viruses and really stayed with us up until 2009, when we had a new pandemic and different or novel H1N1 virus that supplanted or replaced our existing seasonal influenza. And in actual fact, we know even from looking at the 2009 virus that part of the reason that it probably was milder than we would have anticipated from a pandemic perspective was because, again, although it was a new constellation of gene segments. So influenza viruses have segmented genomes, which means that they can reassort and recombine quite a lot. We know now that the 2009 virus really, although it was a novel reassortment or a novel collection of gene segments, it wasn't really completely novel in the sense that it was coming from an avian reservoir or crossing the species barrier, as we've seen with SARS coronavirus type 2. And I think if we look at the last century of influenza viruses, if we're trying to take some information from that or some knowledge from that might give us some guide as to what SARS-CoV-2 will do. And generally speaking, when viruses come into the population, they tend not to disappear unless they're replaced by something else or unless we get to a level of significant population level immunity. But we know, again, if we look at the human coronaviruses that we have to date, the ones that cause the common cold and typically undergo or see a peak in activity every year. We've OC43, 229E, HKU1, and NL63. So two of those were discovered in the 1960s, and two of those were discovered in the noughties. So we really probably don't envisage SARS-CoV-2 going anywhere anytime soon. purely because it's found a susceptible host. It's managed to establish itself in the population quite readily. And while it might, over the course of years or decades, become milder, we don't know when our existing human coronaviruses cross the species barrier, but it's likely that when they did, they probably caused more severe disease than they do now. As with any pathogen going into a new host, typically it can be a little bit rambunctious when it first gets there. But even if we again take a lead from influenza, we have a very good vaccine against influenza. It's not perfect, that we receive on a yearly basis. But even with a very good vaccine, and we probably haven't had the level of uptake that we need to try and eradicate influenza. But generally speaking, from an infection perspective, if we look at viruses that have an animal reservoir, then eradication really is never an option for us. So thankfully, with polio, we've been able to we're getting very close to eliminating that globally. Smallpox we were able to eliminate. But really, it's a challenge to eliminate anything with an immunization policy alone. We're getting close with measles and rubella as well, and again, that's because they don't have an animal reservoir, and humans are the natural host. But certainly, I think if we look at what we can learn from influenza, despite the fact that it's a different virus, I think what it tells us about SARS-CoV-2 is that it's likely to stay with us for quite a while, even if we do manage to get a vaccine in the next 6 to 12 months.
Okay, thank you, Killian. They're pesky little buggers, these viruses, aren't they? And there appear to be thousands of them, many of which never come to full fruition and exploit us as hosts in the way that we fear they might. But it's grim, I suppose, to look to the future and see such a long period of time without any relief. We hope that may ultimately not be the case. Fintan, you've been writing about some of the aspects of our current handling of COVID-19 since it all began. Do you want to tell us how we've done here, and maybe talk a little bit about elsewhere, our next door neighbours across the water? And if you want to talk a little bit, if it suits you to, about nursing homes, direct provision centres, the whole institutional burden, if you like, of what's happened with the virus here.
So I'm very conscious of being the person with the least expertise on this distinguished panel. So I'll probably wander off into sweeping generalizations, which is what I tend to do. But pandemics or plagues, as I suppose they were called for most of human history, are themselves almost like investigative journalists. You know, they find out the things which have been hidden. It's very striking that if we go back 2,500 years to one of the great foundation stones of Western art, Sophocles' play, Oedipus the King, what's happening in that play? Well, you know, there's a plague, and the plague forces the city to find out what's wrong. There's something hidden, which of course is that Oedipus has killed his father and married his mother. But it's the plague that sort of is the pressure point that reveals the truth. And what I suppose what pandemics tend to reveal is what I've called in other contexts, stealing from and adapting Donald Rumsfeld, the unknown knowns, the things we know about but don't want to know about, really, that we've kind of put out of our minds. And I think there, in this episode of our own history, just two things have really struck me. I mean, one is a general complacency, and this is absolutely not true, of course, of my fellow panelists who are you know, been working in these areas for so long, and so many, and Ida as a historian. But I would say, in general, in the society, and maybe this is true of most Western societies, we become extraordinarily complacent about the idea of contagion, of airborne diseases. I'm old enough, as I think possibly you might be, Katrina, to remember, you know, just how conscious we were as kids of polio, of tuberculosis. You know, the X-ray van outside the Bank of Ireland, you know, in Dublin. I'm sure in similar things in most Irish cities. Kids with calipers in the class beside you because of the polio epidemic. Signs on the buses saying "Do not expectorate." I learned the word expectorate when I was 3 or 4 from being on the bus, because people spitting, people coughing, people sneezing was bad. And a huge amount of that had just been sort of forgotten, I think, because we've been fortunate to be in this bubble when we haven't had a huge threat from a specific plague other than AIDS, which was, of course, very much framed as being about specific groups of people, probably wrongly, but I think that's very much the way it was thought about in society. And we've suddenly had to know this unknown again, and so there is a shock, which I think hits the general population in relation to this, which might not have been the case at most previous times of history. Most people would have expected bad news coming in the form of airborne infection. The other unknown known, of course, is institutions. And it's very striking to me, anyway, that the things we've known, particularly about residential institutions, for a long time, is that they're not great places for people to be. And this is not a criticism of, there are some fantastically run nursing homes or some fantastically run residential institutions, but these are not places that people resort to voluntarily. We've known for a long time that all studies of older people say, do you want to end your life in residential care? The vast majority of people say, no, I want to be at home. So we've sort of known this, and we've known that there are alternatives, and that there are alternatives that we should have been exploring and developing of care in the community. I think everybody accepts some people have to be in residential institutions, but there are probably very large numbers of people, both older people and people with disabilities, who don't want to be in these institutions and probably shouldn't be if we had, as a society, reorganized ourselves so that they could be kept within the community. And of course, direct provision is a very, very striking example of that. It's probably the worst. Direct provision is in some ways our contemporary equivalent of the institutional incarceration, of which we are so rightly ashamed historically. But we've been doing this to people, including to children, for a very long time, and we've known again that it's not a good thing to do to people. And what the pandemic does is then it comes along and it sheds a light on these institutions and on the danger that's there. And it brings to mind just that horrible old cliche, out of sight, out of mind. If you're not seen, if you're not understood to be part of the community, then when something like this happens, you are in danger. The solidarity, the mutual support, the mutual awareness that kicks in when, as a society, we try to deal with these things, just isn't there for people who have been physically segregated out. And I think this is one of the things that we saw in the Irish case. I've always been very reluctant to criticize people who are trying to deal with the pandemic, because it's a horrible business. It's horrible psychologically. I'm sure it's really terrible in terms of people's workload and all the rest of it. But there is no question but that we left nursing homes and residential institutions out of mind to a very large extent in the early stages of the pandemic, and that's where most of the death was. I mean, that's really where the fatalities happened. And I don't blame the people who are specifically trying to deal with the problem as a whole in this really incredibly difficult context. I think the real blame for that lies on a much wider level as to how we've allowed these areas of our society to be marginalized, to be segregated. Not just in terms of the residents, but remember also in terms of the people who work in them. So very large numbers of people working in these institutions who are on minimum wage, who are working for agencies, who don't themselves have sick pay. Remember, we've got a lot of carers who are not entitled to sick pay. These are structural things that we have allowed to happen. So where does this leave us? I think perhaps what it tells us, and if we look at the British on the one side of us and the Americans on the other side of it, we feel a certain gratitude. Heinrich Böll, the German novelist, always said that the classic Irish, the characteristic Irish statement was, "It could be worse," and it could be worse. We have been relatively fortunate in the quality of our political leadership. However, it also could be better. We don't have room for complacency about this, and in particular, I think because we've moved out of the immediate emergency phase of this into the sense that this is a long-term challenge, I think there's a critical need to broaden the political discourse about it. It's a medical challenge, but it's a medical challenge that highlights social challenges. It really highlights very, very obvious things that we needed to be doing. And if I am critical, it's on that level of, the broader all of government's approach that we're supposed to have to these things, I would argue has been often very badly missing. And I'll just finish with two very simple examples of that. One is dealing with sick pay. Again, something, Ireland's one of the very few European societies that doesn't have mandatory sick pay. Yes, the state has stepped in and tried to fill that gap, but there's still huge numbers of people who are in very, very uncertain conditions around all of that, and that definitely affects their behaviour. That could have been fixed and should have been fixed. A second obvious thing, just a very small point of detail, but I think it just shows what I'm trying to get at. If you think about going back, schools going back, for example, a critical thing for the society, or to get the schools back, I completely agree with that. Why were we not planning in April, in May, for how do you do that spatially, right? Well, one of the things you might want to do spatially is get prefabs in, for example. You can't build a prefab in a school without planning permission. You can't get planning permission for 6 months if you're really lucky, probably longer. There's nobody saying when schools are going to go back, should we have a change to the law that says in this immediate emergency context, if you're a school, you can bloody well build a prefab if you want. So there's a whole layer of social and political decision making that I think is necessary beyond the medical. And I think as time has gone on, those things have become more and more critical to us.
Thanks, Fintan. And when we come to the end of the second round, you're going to have time to talk to us a little about what outcomes you think there might be ideally from the so-called learnings that we've all got from the pandemic, precisely the kinds of things you were talking about, changes in infrastructure, in systems, and in the philosophy, I suppose, of government and society that might, if we're lucky, result from what we've all gone through with this. Ida, I'm going to start with you on this second round, and I've two things to ask you. One is, could you talk to us about the similarities and dissimilarities between the 1918-20 pandemic and now in terms of infection control, public health measures, treatment, if any? I don't think there was ever a vaccination, at that stage anyway, against the flu. And, how like or unlike are they to what we're doing now? And one of the most interesting chapters of your book, this is the second question, is the global amnesia that settled in after the end of the Spanish flu, where it wasn't written about or talked about for a very, very long time. Now, we know it coincided with the end of World War I, where there was a devastating amount of death to deal with. This was extra death on top of that already devastating burden. So it's possible that was the reason. But it was fascinating to me when I read your book that it was epidemiologists, not historians, who started to investigate the Spanish flu of 1918 to 20, much, much later in the 20th century. Could you talk to both of those points?
Certainly. I'm fascinated that both you and Fintan have raised the idea of pandemics, epidemics, casting a light on society. And Paul Slack, the historian, talks about this, that they show up the major flaws in society and what's wrong with them. But that's just a quick reflection. In terms of what happened, what kind of treatments were used, that kind of thing. It's probably very much a picture here of what it would have been like without lockdown. It's really swept around the country here in Ireland quite quickly in 3 waves. In May, June 1918, in the autumn, winter of 1918, and then again in the spring of 1919. The doctors, very much like today, a mirror image. They scrabbled around, scientists and doctors scrabbled around to try and find treatments. They couldn't come up with any one solution, so they seemed to throw everything in their doctor's bag at it. And the Royal Academy of Medicine had a big meeting on the 15th of November 1918 to try and get everybody from the different major Dublin hospitals in particular to pool ideas. So there were curiously using treatments that are quite similar to some of today's treatments. Quinine, for example, an anti-malarial remedy, which was then a very common anti-fever remedy, was one of the main remedies they used. They also used calomel, which is mercurous chloride. And I think doctors used that as a kind of a smoke and mirrors thing, that it had the immediate effect of making the patient want to get out of bed to go to the loo. So if you had to sit on the pot when you had previously felt you couldn't budge because the flu was so bad, perhaps that is something of a confidence-inducing measure. Whiskey and brandy were given out in copious amounts by the older doctors in particular from some of the accounts. But whiskey and brandy would have been a normal part of hospitals and the workhouse store cupboards anyway. They gave it out quite frequently to help people sleep, and I suppose also in flu it would help to ease, make you a bit sleepy, and also ease if you were given it in hot whiskey, ease the kind of respiratory aspects. It spreads in a very similar way, of course, because it's an influenza and it spreads through respiratory droplets in a very, very similar way. So when I saw this first coming from Wuhan and spreading ever closer, and you're watching it, a lot of my work was through the newspapers. It seemed to spread in a very, very similar way. And I suppose that had my antenna up very quickly in early January about it. And I think my students at college and my fellow staff probably thought I'd quite lost the plot because I was so convinced this was going to be something really big at the time. But it was such a close echo in so many ways. And the whole idea of medical puzzle, I suppose, is very similar too. In terms of the amnesia, I know Fintan has written in the past about his own family and the impact of disease on that. One of the reasons I think it was forgotten is that disease was such a big part of normal life in Ireland and even in other countries, relatively well-developed countries like Ireland at the time. 20% of the annual deaths on the island in any year in the 1910s, it was usually about 70,000 deaths a year, but 20% of those would be children under the age of 5, and they would be, many of them were from disease, but also from conditions of poverty. So you would have deaths from things like measles, bronchitis, pneumonias in the thousands, TB, of course, but also things like whooping cough, scarlet fever, killed in the pre-antibiotic era. Again, it's fascinating, as you say, that it's epidemiologists that first start to count it in the 1920s and then afterwards. And history takes a lot longer to actually see it as being something valid for study. And I think this is partly because social history doesn't really become popular. The idea of the history of the individual and of their health is not all that popular until after the Second World War, and then it snowballs. Alfred Crosby, the wonderful American environmental historian, whose other great work was on the Columbian Exchange, on how biotas transferred forwards and backwards with the discovery of the Americas between Europe and the Americas. All sorts of things like VD are transferred across, and also fevers and influenzas and things are transferred backwards and forwards across the Atlantic at that stage. But his second big work was on another great environmental thing, the Spanish flu. And he really started the ball rolling with such a fascinating and readable study. You know, he gives great details about Woodrow Wilson catching it at the Paris Peace Conference and how that affects his ability to negotiate. And you know, his story, I think, then started Howard Phillips in South Africa, Jeff Rice in New Zealand, Niall Johnson then in the UK, and now we have a terrific network of international researchers from many different disciplines on the 1918 flu, and we're all the time trying to get learnings from that and show how it can be applied in future pandemics. And we didn't expect one to come quite so quickly, I suppose, when we were particularly looking at the centenary in 2018, 2019, and then just a few short months later, this thing happens.
Thanks for that, Ida. It is, you know, it's amazing how things can be forgotten. And of course, you're right. Social history doesn't come into its own until, I suppose, at the earliest, the 1950s. It's why it's so important that we now get access to the records and archives that we need to be able to explore Irish social history in more detail than we have. Luke, coming on to you again. Since issues like testing and treatment and vaccination affect residents and institutions as much, if not more, than the rest of us, what's your opinion of where we are now with those developments?
Well, it's a work in progress, Katrina, to some extent, is the truth of the matter. You know, I mean, clearly we know now there are 4 fronts in this battle. To beat this virus, we have to occupy all 4 fronts. The first is what I might call the medieval front, and Ida would agree, I'm sure. The stuff we're doing in terms of distancing and public health wouldn't have been any different 100 years ago, maybe a little bit, but certainly I got a great thing, Ida, recently about, there was a fact sheet about the Spanish flu with the same instructions almost as we're using now. Wear a mask was even on that, you know, and social distancing, you can't tell the difference. So you don't need much science. So the first front is like it was through hundreds of years, and it is things like quarantine, distancing, hygiene. That was there through many pandemics. The second front is, of course, the vaccine. That's the one we're all talking about. Great progress there. There's cautious optimism, using Tony Fauci's well-worn phrase. It gets more optimistic as time goes by, to be honest. I mean, last week, Johnson & Johnson announced a huge phase 3 trial. 60,000 people will be on this trial. It involves 9 countries. Their vaccine candidate is the same technology they got in the Ebola vaccine, which has efficacy, and they've popped in the spike protein now into that. So, and it's also, it doesn't need to be frozen or kept cold. That's a great advance if we're going to get it into the developing world quickly. One shot. So that Johnson vaccine to me looks like a really exciting one. We now have 5 vaccines in phase 3. I'd say reasonably we'll get readouts, initial results for them if we're lucky towards the end of the year, Q1 next year. We'll know if these have any hope in them, really, you know, and that's tremendous. The third front we're fighting is, of course, therapeutics, my own area. Anti-inflammatories, ways to handle patients in hospitals, keep them alive. We're seeing progress there. Dexamethasone is a steroid which showed a reasonable effect. It was a 20% effect, but that means that instead of 5 people dying, 4 are. That's an advance. We're going to see more therapeutics. I mean, my big optimism, many of us have an optimism around antibody therapies, and there's at least 40 different antibodies in trials at the moment. One that looks especially exciting is the drug company Lilly as a prophylactic. So they're giving that antibody now to people in care homes in the US, and they're trying to see if it will protect them from getting infected. Wouldn't that be wonderful if we can protect the vulnerable now with a therapeutic as a prophylactic? That's going to be a big advance. And again, these are safer, or not so much safer. They're well-worn antibodies. They're kind of used a lot in other diseases, so there's less concerns about safety. Our number one thing to look at with the vaccine is, of course, safety, and that 60,000 patient trial, it's got 60,000 people because they want to make sure there's a strong safety signal here that it isn't going to cause any harm, and that must be uppermost in our minds. And then we get to the testing. The fourth front in this battle is test, trace, isolate. The dream there would be constant testing anytime, any place, anywhere. It could be in care homes, it could be in airports, it could be in schools, it could be in the hallway of your house. Why wouldn't each house in the country have a test? And you test yourself before you go outdoors, maybe 2 or 3 times a week. That's the dream. Now, that's a very tough dream to realise. Clearly, we have the PCR testing, as as Killian well knows in spades. I mean, that's a very sophisticated test. It takes a bit of effort and time and expertise. The next will be the antigen test, which measures protein in the virus. That's a very rapid 15-minute test. So you've never seen such effort. Every major pharma company, remember, has a massive diagnostic division, because when you go to hospital and get tested for anything, that's made by a big company that's well used to doing testing, you see. So every big company now is deploying their best and brightest at devising a very sophisticated, high accuracy test. One example I'm giving is an Israeli company who are trying to make a mask that shows if you're positive from your breath. Can you imagine if a mask gives an indication that you're infectious? What a tremendous advance that would be, because that means stay home, isolate. We can beat this virus through selective isolation of infected people, remember, and if that's done properly at a high enough level. Doesn't have to be perfect. It could be 60, 70, 80% efficacy in the testing would do. Remember, 60, 70% efficacy in the vaccine will do as well, because then the virus begins to peter out. All of this is about getting the dreaded R number below 1, remember. That can be achieved through social distancing. It can be achieved through a vaccine. That's the main thing a vaccine does, by the way. It gets the R naught down to 0.1. That's tremendous, because then it stops spreading, you know. So all of these things are happening in real time, Katrina. And as the months go by, we will see more and more little examples of success on all 4 fronts, I predict. We'll see little indicators that the virus is now being brought to heel. The ultimate answer is a vaccine. No doubt about that at all. It gets rolled out, as we all know, in the vulnerable groups first, and in the healthcare workers. That'll take about 3 or 4 months, they reckon, to see that begin to see an effect. And now we're into June, July, August of next year, if we're lucky. Now remember, there's unknowns here. The thing can fall over. Vaccines have failed in the past. Even worse, certain vaccines make disease worse, and let's hope that isn't the case with these vaccines, but we still don't fully know, you see. But certainly at the moment, you'd be looking at June, July, August, September next year when the vaccine begins to get rolled out. We need more than one vaccine. You won't vaccinate the world with a single vaccine. If 4 or 5 are efficacious, now we can begin to imagine a future where the entire world is going to get vaccinated. And then, of course, guess what? Something that kind of Fintan touched on almost there. I mean, this virus has shone a light on how badly we're handling malaria already, and cholera. There's a big outbreak of cholera happening at the moment. You know, in terms of diseases we can already treat, we're seeing outbreaks of those for various reasons. So what we need is, beyond this pandemic, a much more effective way to deal with infectious diseases more globally. Surely will be one of the outcomes from this pandemic that we're in the middle of now. So that gives you a quick little vista of the coming months ahead of us.
Thanks, Luke. I have a supplementary question which may occur to some of our viewers. The vaccines seem to be all being done by major pharmaceutical companies, some of them in partnership with academic institutions like the Oxford trial. Is there going to be a catfight for profit about the vaccine when one or more of them proves to be safe and effective? And are we going to end up with vast amounts of money being made by pharmaceutical companies, or will there be some sort of international protocol to make sure that the vaccine gets to everybody, particularly the developing world, who won't be able to afford it unless it is made affordable?
Well, Katrina, you know what human beings are like, right? So there'll be greed, there'll be all kinds of traits. There'll be nationalism, politics. We've got to keep banging the drum. The scientists, the FDA, the CDC in America, Gavi, CEPI, these are independent organizations, by the way, that are very effective, backed by philanthropists largely, it must be said, but also governments. The WHO are banging the drum to say, 1, the vaccine must be free to the world. 2, it must be available to those who need it most, you know, and that'll be the more vulnerable groups, and also certain, you know, ethnic minorities. Vulnerable people in this vaccine business, by the way, people who've no sick pay. I mean, if ever there was a virus that shone a light on social inequality, it's this virus. And the reason why it spread through California is mainly because those people had to go to work. They were working in underpaid jobs. If they stayed home, they couldn't feed their children, you know. So if ever a pandemic revealed the horror of social inequality, it's this virus. So we're all very aware of the fear of, you know, a grab, you know. Remember, the European Union's all over this. There's a massive alliance now of European Union countries to make the vaccine available throughout Europe, wherever needs it most. Now, maybe that's a bit happy-clappy, but certainly it is uppermost in our minds, is to make this vaccine available to everybody in the world who needs it. Now it's political. The Russians have got their own vaccine. The Chinese have rolled out 3 vaccines and allowed them to be used widely before a phase 3 trial. If they get there first, what's going to happen there? Will they stop other countries getting access to those vaccines? I don't know. The other thing to mention is the 9 CEOs of the top drug companies have said they won't allow the vaccine process to be speeded up. There's a big fear here of rushing it through. Again, for political reasons, potentially. They've also, we're not having that. You can forget that. You know, this has to go through the safety protocols that are essential for this. So everybody who's anyway, what's the word? Sensible might be the word, or ethical, or a human being is watching the very questions you've asked, Katrina, up close and personal, and over our dead bodies kind of territory, that this will be allowed to certain groups or certain countries or certain vested interests. That cannot happen, would be the view. And let's hope that's the case.
Thanks for that, Luke. That's partially reassuring. We hope that you're right. I mean, part of the problem is that international institutions like the United Nations are much weaker than they have been in the past, and that there's no one organization, except I suppose the WHO, which has issues of its own, that we can all count on. Cillian, as part of the whole virology exploration story, testing must have been something that I don't know the answer to this, which is why I'm asking you. When did people start being able to test human beings for being infected by viruses? Is it a relatively new thing? Did we count on symptoms up to a certain point? I mean, in this case, we're looking at asymptomatic carriers of a virus who often shed the virus and transmit it before they show symptoms. When did testing begin, perhaps tell us?
If we look back at virology, I suppose traditionally it would have been a fairly slow process to diagnose infection. We first visualized viruses back in the 1930s after the development of the electron microscope. And then afterwards, we would have, in essence, cultured viruses in cell lines or in animals. So if we look at when the first influenza virus was retrieved from an infected individual, it was in the 1930s in London, and that was where the virus was grown in a lab. Now, viruses can take a number of days to grow, or some more slow-growing viruses take a couple of weeks. So from the point of view of turning around results very quickly, cell culture wasn't, I suppose, particularly effective. So an awful lot of diagnoses would have been clinical in years gone by or in decades gone by. And I suppose that was helped in part by the fact that a lot of, certainly respiratory viruses, people would recover before the need for a diagnosis was there. What probably revolutionized diagnostic virology in many respects was HIV, really, which Luke has alluded to earlier, in part because it was the first, I suppose, virus that came around at the time when the polymerase chain reaction or molecular diagnostics had just started to come to the fore. So in some respects, the way things happened in the 1980s, HIV sort of came into the human population at the right time. Had it come in sort of a decade or 20 years earlier, I think it probably would have caused an awful lot more damage than it did. So what happened with PCR in the middle of the 1980s was that it allowed us to amplify very small amounts of either DNA or, for some viruses, RNA in the bloodstream of individuals. That was what happened for HIV. We were able to monitor the viral load, because one of the things that happened with HIV was that people, after they were initially infected, were often very well and asymptomatic for about a decade. And people thought it was a bit like the herpes simplex, the cold sore virus, that the virus was just latent and wasn't causing any damage. But actually it was a chap called David Ho in the Aaron Diamond HIV Center in the States demonstrated that actually what was happening during that decade was that the virus was replicating at an incredible rate, and and Luke will know this better than me, was basically consuming all of our CD4 cells, which are a key component of the immune system. So what happened during that apparent period of latency was that actually your immune system was being decimated, and then people died of cancers or opportunistic infections that people with an intact immune system wouldn't necessarily suffer from. So what we're using today now is, so PCR has obviously changed since the 1980s, but in essence, the way we used it for HIV allowed us to apply the same thinking to the likes of hepatitis C or CMV or even influenza and other respiratory viruses. So PCR is really sensitive, it works really well. But again, as Luke has alluded to, it does require a level of expertise, it requires a level of investment, and typically some sort of specialist knowledge within a laboratory, sort of a medical microbiology laboratory or virology laboratory like ourselves. And that can make it, I suppose, not terribly applicable or not terribly useful for some low and middle income countries, and also can make it challenging when you want to try and bring testing into a sort of a non-laboratory setting, so either in the community or in the home. But I think in the broader sense, for outside of virology and testing, I think what this pandemic, I suppose, has highlighted is how unprepared, I suppose, our health service in Ireland is for some event like this. Now, granted, thankfully, these events are quite rare, but we know that our hospital system reaches capacity every winter, just with straightforward influenza. And influenza is not unpredictable. We know when it's going to occur, give or take a few weeks every year, but yet our hospitals are over capacity typically by the time we reach the winter season. And that's really is a situation that we shouldn't accept as a I suppose, sort of first world country at this point in time. We know that hospitals should be operating, generally speaking, at a capacity of about 75 to 80%, so that you have that surge capacity when something goes wrong, whereas in Ireland, we're typically operating at a capacity of about 100% or even over 100% in many of our hospitals. We also know that we had significant challenges in March and April around laboratory testing capacity for SARS-CoV-2. Now, to be fair, there was an element of a global supply chain issue associated with that, but also we know that we didn't have the infrastructure on island within our hospital laboratories and within our own laboratory here at UCD to be able to test the number of specimens that we wanted to be able to test on a regular basis, because obviously testing in and of itself isn't a magic bullet, and it doesn't control the infection, but it's a vital component of the public health response, because it allows us to interrupt chains of transmission, and it allows us to isolate individuals and to inform the contact tracing process. So I think what we need to do from a diagnostic perspective now is, in essence, bring it as near to the patient as possible, and to make it as readily available as possible. But that does require an infrastructure that wasn't there previously. And I think it comes back to an earlier point that Fintan made. Us was one of the things that has been most striking for me in the course of this pandemic has been the way our society has been revealed to be flawed in many respects. If we look at the institutions affected, be they nursing homes or direct provision centres, and actually the prisons have done remarkably well in the context of this whole situation. But what we saw about direct provision centres and about nursing homes was that the staff in those, and the meat processing plants as well, of course, the staff in those settings often had to work in more than one location to get to a living wage to support their families. They didn't have sick leave, or sick pay rather, as people have said. So in essence, they were going into work while symptomatic, and that's not to criticize them. They obviously had an horrendous choice to make, but certainly speaking for myself, before this pandemic, I wasn't aware of the challenges faced by staff working in the healthcare setting and working in our nursing homes. Obviously, the majority are based within the private sector, but the HSE, I think, has ownership of about 20%, and perhaps that was willful ignorance on my part. Similarly, I didn't realize the pressures that people in the food industry, we all see lower prices in our supermarkets on a weekly and a monthly basis. And we probably don't think about the process that food goes through to get there. We heard stories from the meat processing plants of people living together, sharing accommodation, sharing transport, often sharing beds on a shift type rota system, purely because they couldn't afford anything else. And then the same individuals who are working in our meat processing plants or who are working in our nursing homes and residential care facilities were themselves staying in direct provision centres, crowded into bedrooms with members of other families, so they didn't even have a room to themselves or with their own family. So physical distancing was fairly impossible for them. So I think the medical side of this is obviously key, and I think it needs. This is going to happen again. You know, we're at 2020 now. We've had 3 sort of cross-species transmission events from coronaviruses alone in the first 20 years, with SARS, the original SARS at the end of 2002, we had MERS in 2012, and now SARS-CoV-2 in 2019. And there are hundreds of coronaviruses in bats, which we know because of surveillance that was carried out after the original SARS coronavirus in 2003. Thankfully, those first 2 viruses didn't really get very far. They didn't become readily transmissible between humans, but SARS-CoV-2 has managed to do that. And as I said, it's likely to happen again. It's not really a question of if, it's more a question of when. So I think what we need to try and learn and take from this is that we need our system to be better equipped in the future than it is now. And I think that means we need to be in a position where we can accept the fact that 10, 20% of our beds will lie vacant in hospitals, and that's okay. You will have empty wards because you have capacity, and you're keeping that spare capacity there for whether it's a bad winter season, or whether it's for a pandemic or a particular outbreak, or just so you can rotate the wards to allow, or to prevent the increasing incidence of antimicrobial resistance in various drugs. So there's a huge amount that we need to take from this. Diagnostics obviously is a key part of it, but to be fair, I'd say that the HSE and the department have invested a huge amount in putting in place the testing capacity over the last 6 months. But we've seen that the numbers are probably just going to keep increasing, and in the absence of a vaccine, if we want to keep our children back in school, and we want the universities to open, and we want to allow our society to return to some level of new normal, then testing is a key component of that. But also it's about having the infrastructure in place more broadly across our primary care settings. Obviously, the community hubs that we had established for SARS-CoV-2, they never existed before in Ireland. We weren't able to use GPs because of the risk of infection. We've obviously redeployed a huge number of people from non-medical tasks to swabbing in the community, to contact tracing, and all of those people will go back to work, and the system will be under pressure again. So I think it's a question we need to ask ourselves as a society, whether it's a 1-tier system or a 2-tier system. My personal views, I suppose, aren't really relevant, but I think we need to figure out and decide what type of health service we want to be able to provide for people, and one that will care for people from the cradle to the grave. And as I said, I would take on board Fintan's point earlier about the nursing homes. It's very difficult to look back on that setting and feel that those individuals weren't failed in some way. It certainly wasn't willful, and there was an awful lot of virus in the community. And it's difficult even now to look back to think how you could have insulated that group completely, just given the nature of the fact that staff needed to go in there from the community. But certainly I think it's a salutary tale for us all as we move into what's likely to be a challenging winter.
Okay, Cillian, that was very eloquent. And I think it's really interesting that 2 of the most influential scientists in Ireland at the moment have both alluded to structural inequality, to the way we run our society as something that played a very deleterious role during this pandemic. Killian, I have one more technical question to ask you. Forgive me. The whole testing thing has become a matter of public interest, obviously, and I know that everyone has been doing their best, and the PCR test is what is used. There was a segment in the press recently about a new, relatively new antigen test that's being piloted in County Roscommon, in schools in the agricultural area where there are congregations, which is much more rapid than PCR. It may not have the same sensitivity, but it may have a reasonably good effectiveness. And the HSE is a partner in this pilot scheme, so I presume it might be something that you're aware of and know about. Could you tell us what you think about that as a possibility for the future?
Yeah, of course. I think it's really important for people to appreciate that we're very open to trying new tests and new assay platforms as they become available and as they come to market. I think we have to be cautious about moving into new areas just because it seems to be, I suppose, the fashionable thing to do in some respects. We don't, at this point in time, really use antigen testing for anything else. That's primarily because PCR is so good, primarily because antigen is less sensitive, and obviously we haven't been in this situation before. So I think antigen is certainly something that we can look at. The problem at the moment is really getting good real world data that we can choose to evaluate the various tests, because if we look typically, obviously, for the likes of the PCR assays that are out there, and the large assay manufacturers have have published data on the performance of those assays that we can evaluate and compare with each other. If you look at antigen tests, there's a huge amount of focus and interest on them in the lay media, but there's not a huge amount of high quality evidence available, and that's to be understood. That's not necessarily a criticism. Obviously, it takes time to generate real world data that companies can share, but it is a challenge when you're trying to decide what to roll out within a community and within a testing strategy. So certainly we have plans within the HSE. I'm not familiar with the test that is being used in Roscommon, but I know there are plans within the HSE to work with a couple of existing suppliers to evaluate antigen tests as they come to the market. And from an NVRL perspective, antigen testing would tend to be more near patient. So if we can support that work, we will, but probably from an evaluation perspective, it would make more sense to do that on site, whether it's in a hospital lab or whether it's in one of the community sampling hubs. But I think antigen will have a role to play. As you said, it's less sensitive. The general principle with antigen testing is that you can overcome that lack of sensitivity either with your frequency of testing or by the number of tests that you perform. So for example, if you have 20 people in a classroom or 20 people in a workplace and you're concerned about a SARS-CoV-2 outbreak, if you test all of those individuals with antigen tests, you're very, very, very unlikely to get 20 false negatives, if you like. So you can overcome that sensitivity because you're testing a large group without having to take samples and send them to a laboratory for PCR-based testing. But at the moment, it is really a question of just, I think we do need to ensure that the quality of the testing that we introduce remains high, regardless of the platform. And as I said, people will be familiar with the fact that we're doing work on saliva testing as well. Again, there might be a little fall off in sensitivity, but from the point of view of it being a less invasive sample, an easier sample to take, certainly from, say, children and young adults, and it might be more preferable, let's say, in a serial testing capacity where people are having repeat testing done over a number of weeks or months. Again, I think saliva may well have a role to play, but it's a departure from what we normally do, and I think it's just important that from a laboratory perspective that we maintain our standards and ensure that we don't just introduce the new thing, the new methodology just because it's shiny and there's a lot of focus on it. I think we just have to make sure that everything goes through a robust evaluation and validation procedure, as we would do with any other test. Obviously, I appreciate that there's a time pressure on this, so we want to get it done quickly. But as I said, for me, the most important thing is getting it done in a safe and effective manner. It's obviously, it's not a treatment, it's not a vaccine, but it's still important that we generate accurate results in insofar as we can.
Okay, thanks, Killian. It would be great if that could move forward quickly and give us the opportunity for much more rapid testing than we have at the moment, and also not have people having to isolate for long periods when they don't have to, particularly in an environment where there isn't sick pay for a large number of our workers. Fintan, you're going to get the last word. Lots of words if you want. You've heard two of our most eminent scientists take up what you said about structural inequality, about the fact that there are flaws in society that were here long before the pandemic arrived, that exposed even further. Are you hopeful that we will learn something from all of this and change some of the things like our health service after it's over? Or are we perhaps doing that now?
Well, I am hopeful, but I would sort of stress that we're on a knife edge with all of these things. I think the politics of all of this and how it plays out is going to be crucial. I think there are four things, and I'll very briefly just touch on them really, that have been brought to the fore around this. And in all of them, they're not abstract issues, right? They're very much entangled with the very deliberate political movements which have sought to destroy things and which have been in the ascendant, right? So the first of these is the assault on science and on expertise. You know, we've had the pleasure of listening, you know, to Luke and to Killian, and if there's one good thing that's come out of this horrible experience, it's that you know, we've had rock star scientists. We've got a public awareness of the brilliance of this, so much of this work, of its importance, but also of its public spiritedness. You know, of the fact that the vast majority of scientists, particularly those who work in independent institutions like universities, public health institutes, are in it for the public good, and that this is one of the saving graces of our societies, right? If we did not have these people, the trouble we'd be in would be vastly greater. However, we can't say this without recognizing that there has been a very, very deliberate, consistent, and well-funded attempt to delegitimize science, and more broadly to delegitimize the whole idea that some things are true and other things are not true. You know, so science is by no means an infallible nexus. It's, you know, every scientist will tell you that they operate themselves through trial and error. Error is part of it, but it is evidence-based. It's based on the idea that we honestly try to discover what the evidence is and act on it. And of course, that's also what journalism is about. It's what honest political debate is about. But we've had this very, very consistent, highly driven attempt to undermine all of that. And one of the things that this experience has told us is we have to fight back against that. We have to fight for science, but we also have to fight for the idea of evidence-based understanding of the world around us, and we have to do that with urgency and with passion. Secondly, this is related very strongly to why have we had this huge assault on evidence? Why do we have, you know, on both sides of us, you know, in Britain and in the United States, regimes which frankly lie and take pleasure in lying and think it's fine and fun? Why do we have Michael Gove saying we've had enough of experts? You know, why do we have Trump, you know, denuding so much of American science? Why were the pandemic units in American government taken away? You know, that they were there, they've been established by Obama, taken away. This is active. And the fundamental reason for it, of course, is linked into the environmental question. It's linked to climate change denial. Climate science threatens big interests. very, very wealthy, powerful interests. The carbon-based economy, is fighting back through delegitimizing, defunding science and also truth, right? So you get across the idea that there's no really any such thing. It's all just opinion. It doesn't really matter. And the pandemic comes along and says, well, actually, I'm real, and I don't care whether you think I'm true or not. I can kill you. But there is a strong connection here, I think, between climate change denialism and the assault on science. Again, I'm hopeful that one of the things that may come out of this is that the pandemic has reminded us, and we were talking earlier about amnesia, but it's reminded us of our fragility as a species and of our place on the planet. The planet doesn't particularly care whether we live or die. It's up to us, and our complacency about climate change, I think, is linked to our broader complacency, which is fed into our lack of preparedness in terms of the pandemic. So I'm hopeful that a renewed awareness of danger will also feed into a renewed sense of how much we depend on evidence and how much we depend on science. The third thing, which I think has to change, is the public view of healthcare. I mean, if you look over the last 20 years as part of this complacency about public health, we've had this huge shift from a discourse of health as a public good to health as a private good and as a commodity that you can buy. Even in the middle of the pandemic, there's huge excitement about the fact that you can go out and spend whatever vast amount of money on the new Apple Watch, which will measure your blood oxygen levels, as if that's the most important. That's what health is. Health is you monitoring obsessively your own health. And I'm not saying for a minute that, of course, there are, individual responsibilities about health, about what we eat, about taking exercise, all that stuff. I'm not, for a minute dismissing any of that. But it's been at the expense of a consciousness that health is primarily a public good and that none of us can be healthy if we're not all healthy. That if we allow contagion, if we allow infection, and then if we allow the social conditions that breed those things to continue, then ultimately we all suffer. We all suffer in terms of our health. We suffer in terms of the economy. We suffer in terms of society. So I'm hoping that this has given us the kick that we need to say, and Killian already mentioned this, we cannot afford to have lack of universal care. And by universal healthcare, I don't just mean hospitals. I think we've had an obsession with hospitals. Nursing homes are part of the healthcare system. The health and social care, we need an integrated system. And what we've been doing is moving in the opposite direction, moving towards disintegrating the system, towards having different levels of patients according with how they're paying, with having a mix of public and private in social care. We need to integrate our healthcare systems, and we need to integrate it on the basis of rights, on the basis that everybody has an entitlement to adequate healthcare when they need it, and that's not determined by money. We've theoretically been moving towards a lot of this with the Sláinte Care program, but the pace of that change has been far, far too slow. I hope that this just forces us to say we have to start doing the things we've been talking about at a community level, for example. We know that if everybody knows that we need proper community healthcare. The first port of call should not be an incredibly expensive high-tech hospital. It should be the local healthcare center that you can walk down to or get to pretty fast. And we just haven't been building those at the kind of rate that anybody thinks necessary. I think on current levels, we will have fulfilled the Sláinte Care, the first step, which is the building of the community healthcare by 2050. It has to be by 2025. There has to be a real concentrated public effort to build these systems and to fund them properly. And we have to talk about lots of other stuff in relation to taxation and all the rest of it that's going to follow this. And the final thing is big government. So we've also had, of course, really going back to 1979, 1980, the whole neoliberal revolution of undermining the idea of big government, undermining the idea that government is necessary. Ronald Reagan's brilliantly effective, folksy thing about, the most alarming words in the English language are I'm from the government and I'm here to help. Well, actually, the pandemic reminds us that those are not alarming words. Those are words we need to hear. We need government, and government in the broadest sense. I'm not saying everything is done by a cabinet of ministers, but government in the broad sense of the public realm, which belongs to all of us, which is democratically controlled, which treats us all as equal, dignified citizens, is absolutely critical to our health. And we can't even just think about governments nationally. Pandemics are not national emergencies. The countries which have tried to apply exceptionalism to the pandemics are the ones who have failed. And we see a terrible example of this just across the Irish Sea. The exceptionalism, the world-beating, red, white, and blue British solutions to all of the stuff, whether it's from the apps to the testing regimes, has actually been disastrous. The thing that we've learned about this is that we actually need to get back to global governance. You mentioned the assaults on the United Nations, the weakening of global governance, Brexit, all of these kind of things have been, and this is again very, very deliberate. This isn't stuff that's just happened in the abstract. So we need to politicize in the good sense the lessons that are staring us in the face out of what has happened. And I'm pretty optimistic that we will. We know that humans as a species don't make the right changes when we should. We make them when we have to. And I think the pandemic has put us into a situation where really our lives do depend on changing our public attitudes to those four things.
Wow, that was a terrific summing up of where we need to go. It's been fascinating to listen to the four of you. We're not going to have time for a broader discussion where you can all ask each other questions, which I'm sure you would love to. But it occurs to me that we think of the virus, people say the virus doesn't care, the virus doesn't mind about borders, the virus is vicious, etc. The virus has no choice. The virus can only think about moving to the next person to continue its existence. We, on the other hand, do have choices. And we have choices about how we run our society, how we run our response to this particular pandemic, and whether we want to change for the better when all of this is over, or preferably during, while it's going on, so we have some kind of nimbleness about how we approach all of this in the future. You've all been wonderful. Luke, thank you for our Whistle Stop tour through infection, through the battleground states of viral pursuit of us all. Killian, thank you so much for your eloquent description of society, actually, which I wasn't expecting to get from you, and for telling us about the history of virology and how all of that comes about. And, all my sympathies to you, by the way, in the position you're in, having to manage this in a place, in a country where you realize that everything is not as good as it should be. That is disheartening. And I wish you the very best in the future with it. Ida, thank you so much for being our great national expert on the Spanish flu. That book is a really wonderful piece of writing. It's got all the evidence anyone might need about what happened 100 years ago. And I suppose it's sort of sobering to reflect that we didn't learn all that much from it. We do have short memories, and that's very sad. And Fintan, thank you so much, as always, for giving us some semblance of hope, I guess, that change is at least possible, even if we don't seem to want it right now. That it is possible. It's possible to look to a society that might be better and treat its citizens in a more dignified and respectful way. Thank you all. See you all again, I hope, at some stage in the future. Good night.